CDK4/6 inhibitors have really altered the way we manage hormone receptor positive metastatic breast cancer. We have 3 now that are FDA approved and available in the first, second, and later line setting in combination with endocrine therapy, and one of them, abemaciclib, as a single agent in heavily pretreated disease. These agents have shown very consistent improvements in progression-free survival, and 2 of them have demonstrated improvements in overall survival in the metastatic setting, ribociclib and abemaciclib. Although palbociclib was the first agent on the market and in clinical trials, it has not yet demonstrated a significant improvement in overall survival. Much has been made of this. Some clinicians and experts feel that the drugs are very similar. They're different flavors of a CDK4/6 inhibitor, and other clinicians and investigators feel that there are explanations for the lack of survival benefit in one agent versus the 2 others. Abemaciclib and ribociclib are quite selective in their inhibition of CDK4, and they're more potent inhibitors there than palbociclib is. And abemaciclib is a more promiscuous inhibitor. It hits more pathways than just CDK4 and 6. So perhaps these differences are leading to different treatment-related outcomes. Well, obviously, given these drugs are so successful in the metastatic setting, they've been looked at in the early stage setting. And there have been 4 trials looking at the use of these agents to see if we can reduce the rate of invasive disease-free survival or improve the rate of IDFS for patients with early stage disease. PALLAS was the first study of palbociclib in the early stage setting. Monarch E was abemaciclib for a year in patients with node-positive disease. Penelope B is looking at palbociclib in patients who don't have a path CR after standard neoadjuvant treatment. And Natalie, the only one that's not yet completed enrollment, is looking at ribociclib in higher risk ER-positive disease. A few weeks ago, we heard a press release that PALLAS was actually shut down. In other words, the Data Safety Monitoring Board indicated that it was unlikely to show an IDFS benefit. We have not yet seen the data, but there are rumors that there was a relatively high proportion of patients in the palbo arm who stopped palbociclib due to toxicity. So perhaps we are seeing a lack of benefit because a proportion of patients weren't able to get treatment with palbo and or endocrine therapy for their disease. Some have pondered whether or not the risk level of the patients enrolled was too low for there to be a meaningful difference observed. We won't know until we see the data, hopefully this fall. And this gave us all pause about whether or not these agents were going to have a role in early stage disease. And then a few days ago, we heard another press release that abemaciclib in the Monarch E study did meet its endpoint and showed an improvement in IDFS for those treated with abemaciclib for a year. So it's a very exciting time. Maybe there are differences in these drugs. Maybe it isn't a class effect. I think that before we get into theorizing too much or changing our clinical practice, certainly, we need to see the data, see what the tolerability profile is, how long patients are able to stay on these drugs, and truly what the hazard ratio differences are in each of these trials. I'm really interested in seeing Penelope B report out as well, which is a higher risk patient population. So maybe palbo will show benefit there. So nothing to change in our practice yet, but certainly looking forward to fall.